Good morning, everyone. I'm Dr. Kim Williams, Chair of Medicine here, and welcome to Internal Medicine Grand Rounds. We are pleased this morning to have a remarkable relatively new faculty member here in our cardiology division and our electrophysiology section. He's an expert on all things advanced interventional electrophysiology. Dr. Atreya originated from Katurba Medical School in India, and he spent a fair amount of time at Johns Hopkins earning an MPH there and doing a lot of quality and safety work. He actually is a bit of a Michigan Wolverine, where he did his cardiology fellowship and structural cardiology fellowship, and then swapped over to electrophysiology, and so he is capable in many ways. Spent some time at University in Massachusetts for his cardiovascular disease fellowship, and has been on the faculty first at University of Arkansas, and now he is here. And it's really great to have a person with this much expertise and the ability to do advanced electrophysiology. And we are looking forward to all that he's going to do for us and his lecture today on interventional therapies for ventricular arrhythmias. Dr. Atreya.
Thank you, Dr. Williams, for the kind introduction and the invitation to speak here. It's my pleasure and honor to be speaking at this forum. So today's topic is going to be interventional therapies for ventricular arrhythmias. And here are my disclosures. None of these are active at this point, but these are proctorship disclosures. But from a learning objectives for today, I think the first goal would be to differentiate the major subsets of heart disease that can lead to ventricular arrhythmias. I'd like to highlight these because understanding these different subsets is crucial for figuring out a management plan for them. And then, since the topic of today's talk is interventional management, we will speak about the key concepts of ablation of these ventricular arrhythmias using a catheter. And then at the end of the talk, I'd like to outline some of the newer techniques and the newer concepts and technologies coming out for interventional ablation of ventricular arrhythmias. So at the outset, I think just a brief overview of the ventricular arrhythmias that we will talk about. Premature ventricular complexes, as you all know, is any extra beats coming from the ventricle that is premature in origin. And by definition, it's either one or two extra beats, because three or more beats together constitute ventricular tachycardia. In some ways, these are on a spectrum. And ventricular tachycardia is either non-sustained or sustained, sustained being more than 30 seconds. And then ventricular fibrillation, we will not talk about. There are newer sort of catheter ablation techniques for ventricular fibrillation, but I think it's still very early on in our understanding of that. But from a PVC standpoint, this is typical. This is a patient with sinus rhythm and ventricular bigeminy, usually associated with a host of issues that you would have all encountered in clinical practice. And ventricular tachycardia can come in a few flavors. So this one, as you can see, is sustained, pretty rapid wide complex tachycardia. And you have the classic EKG definition of, finding a captured beat, a sinus rhythm beat, sort of clinches the diagnosis of VT in this patient with wide complex tachycardia. But this one has a little bit of pleomorphism, which means a change in the QRS morphology. And seeing this on an EKG may give us a certain clue as to the etiology, versus seeing this sort of a ventricular tachycardia, which is more sustained, very regular looking, what we call the monomorphic ventricular tachycardia, broad. And this may be a more reentrant. This speaks a little bit to the mechanism of the VT itself. And then if you look at the 2019 expert consensus statement, which is a very useful document when we're talking about this field, co-chaired by Dr. Bogan from the University of Michigan, who I trained with. So the top panel shows monomorphic ventricular tachycardia. All of them have the, basically same morphology, single morphology. Pleomorphic means that you have some changes in the morphology, particularly if you look down here in V5, there's some changing patterns. And polymorphic ventricular tachycardia is this typical thing that we would all call torsades. Now, polymorphic VT and torsades are differentiated, are basically the same thing. The difference being torsades, DuPont means polymorphic VT occurring in the setting of a prolonged QTC. So that diagnosis is based on the sinus rhythm EKG, but this is what polymorphic VT would look like. And then ventricular fibrillation, I always say this is very rare to get it on an EKG. Pretty much the only time you'll see that happening is someone with VF on an ECMO and perfusing the circulation and giving you enough time to get a 12-lead EKG. Okay, so we are trying to understand what are the different etiologies that can lead to these ventricular arrhythmias. And if you look at a vast majority of them, it's going to be in people with some sort of structural heart disease. Now, ischemic is one big category, and these percentages may change over time. Traditionally, our understanding has been this has been pretty much a sort of a downstream effect of coronary disease. You may either see in acute coronary syndromes, as you all know, sudden cardiac death may occur, but that arrhythmia flavor is ventricular fibrillation. And the treatment of choice there is to treat the acute ischemia. That's not the sort of ventricular arrhythmia that we are talking about here. We're talking about arrhythmias that we can treat with catheter ablation, and that's going to be the downstream effect of NMI. As we have a lot more survival of acute coronary syndromes in the PCI era, post, after the thrombolytic era, we have a lot of patients with large scars. So these chronic myocardial scars caused by myocardial infarctions result in remodeling and setting up of reentrant ventricular tachycardia, which is what a lot of us, everyone in practice will see. Now, there's always a subset of patients with structural heart disease without ischemic disease. So a coronary angiogram is performed and they have no significant disease. And this is usually a very heterogeneous population consisting of patients with idiopathic dilated cardiomyopathy. Patients with sarcoidosis would fall into that category. Patients with hypertrophic cardiomyopathy. So several factors, non-ischemic etiologies, all are lumped together in the second category of, the broad category of non-ischemic cardiomyopathies. And then outside of that, we have either the idiopathic, where we don't know, where we don't have a cause, but increasingly we are recognizing that there are a lot of primary arrhythmia syndromes that may be contributing. And when you evaluate that patient, their echocardiogram, their MRI, it's all going to look normal. So you need to have a high degree of suspicion to perform some sort of genetic testing to evaluate this. So these are sort of the three broad categories. And then this is a nice figure in the 2022 ESC guidelines for VT management. And this just shows you on the left panel, the increased role or increased understanding and identification of genetic risks and triggers for ventricular arrhythmias. So let me see if I can pull out a laser pointer. Okay. So let's put this one out of the way. Acute coronary syndrome still responsible for a large number of VT. PVT stands for polymorphic VT, MVT stands for monomorphic. And you see in acute coronary syndromes, as we all know, it's always polymorphic VT-VF. And this is something we see in the older population, 50 and above. Those who survive myocardial infarction and have some sort of ischemic cardiomyopathy with reduced ejection fraction, we look at that in the chronic CAD. And again, that's an older population, but the difference now is you have scar tissue and you have reentrant, stable, monomorphic reentrant ventricular tachycardia, highlighted by this graphic here, which shows the preponderance of monomorphic VT. But let's look at the things outside of that. The next category I said was non-ischemic. In that, we would include sarcoid, which can cause cardiomyopathy, infiltration. And that's generally a population that's younger than coronary disease. And whether you see polymorphic VT or monomorphic VT, again, depends on the phase. In the early inflammatory phase, you're more likely to see polymorphic VT and VF. In the stabilized scar phase of sarcoid, you will see monomorphic VT, which is why there's a balance of the two. Hypertrophic cardiomyopathy, another important subtype of non-ischemic, younger patients with arrhythmias. Any dilated cardiomyopathy can present with ventricular tachycardia, and you get that idea. And a few important primary arrhythmia syndromes, CPVT standing for catecholinergic polymorphic VT, very young patients, genetic mutations in ryanodine receptors, exercise triggers, long QT syndrome, again, a host of channelopathies that can be, and ventricular arrhythmias can get triggered for a multitude of reasons. Younger patients, a lot of women. BRS is Brugada syndrome. This is specific populations with the genetic abnormality in typically the sodium channel SCN5A mutation, and they present with epicardial RV arrhythmias. We have, and so on, ARVC. These are sort of the important four primary arrhythmia syndromes to consider. And then RTOF is repair tetralogy of Fallot. Again, as we now see a host of patients who have survived their childhood severe congenital heart disease that has been repaired, and we have an adult congenital population, we're seeing more and more arrhythmias in this. And tetralogy of Fallot with repair is a very classic congenital heart disease that presents with ventricular tachycardia in adulthood. I'll finish this section of the brief sort of the overview of the etiology with this slide. So I think this is a very important paradigm to have in your mind. When you have a patient presenting with ventricular tachycardia, the first and most important step is to figure out if this patient has a structurally normal heart or a structurally abnormal heart. The sort of bias we have in our mind is that they have structural abnormalities, and it's actually easier to deal or understand the mechanism or the underlying etiology when they have some structural heart disease, because it's either ischemic or non-ischemic. You get a coronary angiogram. If it's ischemic, you know how the natural history of that is going to play out. If it's non-ischemic, some sort of advanced imaging, which I will allude to later in the talk, and you'll make a diagnosis of idiopathic dilated or ARVC or HCM. This requires genetic testing, ARVC, but the imaging has a specific pattern on the cardiac MRI. Cardiac sarcoidosis, Chagas disease, especially in Brazil and South America, where trypanosoma cruzi is a problem. And then I would add that congenital heart disease, repaired congenital heart disease, is another area of patients with underlying structural heart disease. Now, what do you do with the patients that have structurally normal hearts? So there, it's very, very important to get a genetic test and rule out or rule in primary arrhythmia syndromes such as Brugada, long QT, short QT, CPVT, which on echo and MRI will be completely normal. And if there's no genetic abnormality, there's still some flavors of idiopathic VT that, again, this can be a PVC or VT. And these are outflow tract, which is right ventricular outflow tract or left ventricular outflow tract, which is what typically, these are the VTs that you would try to treat with ablation and not give them an ICD. Pretty much everyone else gets a defibrillator for prevention of secondary cardiac death. But these are very important to understand and identify, because if you treat these appropriately, outflow tract VTs or PVCs or fascicular VTs and papillary muscle VTs, that's more like treating a primary arrhythmia issue, and those patients go on and live a normal life after that if there's no structural heart disease. All right, so with that in mind, the initial evaluation for anyone coming with ventricular arrhythmias is always going to be the typical thing we do when we're admitting patients on the medicine service or the cardiology service. You're trying to figure out, are there reversible causes? Everyone's going to get an EKG, an echocardiogram, but looking for drugs of abuse or other medications that may be interacting, prolonging QT, electrolytes, this is extremely important. If there's severe marked abnormalities here, focusing on just that is going to be addressing the primary issue. Very important to figure out if there is an acute coronary syndrome kind of thing going on, especially if you're seeing polymorphic VT or ventricular fibrillation. Your suspicion is always high for an ACS event, and angiography and revascularization as appropriate if a culprit lesion is identified is key. But let's say that we've done that initial evaluation, and then almost pretty much in the modern era, almost everyone, we are trying to get them to get a cardiac MRI. Even if it is ischemic cardiomyopathy, a cardiac MRI up front is often very helpful in guiding management down the line. Because, especially if you're implanting defibrillators, it's nice to get cardiac MRIs before the defibrillators, because you have the scar information without the artifact from the metal device, that is going to be helpful for future ablation planning. I would say adjunctive testing of endomyocardial biopsies, signal average EKGs, it's a very small minority we would do this in. This would be in someone that we're struggling to find a diagnosis, someone like an elusive cardiac sarcoid, perhaps isolated cardiac sarcoid, you don't have any other areas to biopsy and get a tissue diagnosis. You would consider an EMB or an endomyocardial biopsy. Signal average EKGs, classically, important in the diagnosis of ARVC, where we're looking at a lot of late activation, late potentials that we are detecting on the EKG and sort of summating them. And genetic testing, I think, with reduced cost and increased availability, this is very important. And on service here at the university, we've seen a lot of genetic arrhythmias that have shown up. All right, I want to highlight this. It's very important to think about the etiology or the substrate. We say substrate because that's the sort of petri dish that this arrhythmia is being cooked in. It's important to understand if that patient has a normal heart, the so-called idiopathic ventricular arrhythmia, or they have structural abnormalities. I would say it's probably a 20-80% split. 20% may have idiopathic. And a lot of patients that we see in adult cardiology will have some sort of structural heart disease, either ischemic or non-ischemic, depending on where you live and what burden of coronary disease exists in that area. So let's then segue into the idiopathic ventricular arrhythmias. Again, by definition, this means there's no structural heart disease on a cardiac echocardiogram or a cardiac MRI. If you have access to cardiac PET imaging, it's useful to rule out inflammatory myopathies that may be presenting with ventricular arrhythmias. They will have a structurally normal heart, but on FDG PET, there will be uptake because there's active inflammation, that's active sarcoid or active myocarditis or something like that. Useful to rule out primary genetic arrhythmia syndrome because the management strategies are going to be slightly different. And these will often present with repetitive premature ventricular complex from one part of the heart. And if they are strung together and are sustained, it would be ventricular tachycardia of the same morphology. So I'm going to throw this question out there and then just something to consider. A 40-year-old woman with structurally normal heart, ejection fraction 60%, with severe palpitations, EKG with PVCs originating from the right ventricular outflow tract, and the burden is 30% on Holter despite metoprolol use. What is the next best step? So we will speak about the management of these PVCs in a second, but I think just using this question as to frame or give us context of the kind of issues we are trying to manage with these patients is important. So you can the options are using a non-toxic antiarrhythmic drug, a class 1C antiarrhythmic drug such as propafenone or flecainide. These would be options in people with structurally normal hearts. These class 1C antiarrhythmics are not options in people with structurally abnormal hearts. So this is kind of managing, atrial fibrillation. You would use these antiarrhythmics. You could always use amiodarone, but one would argue that is overkill. It's a very strong and toxic antiarrhythmic in someone with a structurally normal heart. And then there's the role of catheter ablation, which we'll speak about in the next few slides. So this is a great slide highlighting the important idiopathic PVC or VT locations from the heart. Dr. Tatanuwat is at IU, and this is a very nice paper that was published a few years ago. So again, if you look at the idiopathics and look at the prevalence of these arrhythmias, the overwhelming majority are going to be the outflow tract ventricular tachycardias. And they have signature EKGs. And as an electrophysiologist, it's important to look at it. But that's basically coming out from the right ventricular outflow tract or the left ventricular outflow tract. And they're structures that are very close together. Outside of these, they can be perivalvular. Just the other day, we ablated one from the tricuspid annulus. Other important structures in the heart that we've got to look for, certain signature EKGs are the papillary muscles, either in the right ventricular, the moderator band, or the left ventricular papillary muscles. The fascicular system, which is the conduction fibers next to the left bundle, as well as you could have a structurally normal heart with one focus of epicardial VT, and that's often tough to get, and they often arise from the so-called left ventricular summit area of the heart. which is an epicardial structure on the outside surface of the heart. And it's a dangerous area and a difficult area to get to because it's surrounded by the left main coronary artery and a fat, and just a difficult area to get to. So I want to emphasize that within the so-called idiopathic ventricular arrhythmias, you may have the easy to manage outflow tract VT, and you may have the really difficult to manage epicardial VT. And they require a completely different set of strategies if they present to the lab, And I think going back to medical school, these are the important mechanisms of all idiopathic ventricular arrhythmias. Often triggered activity and abnormal automaticity are the primary cause of this arrhythmia that's arising in otherwise structurally normal heart. It's a local problem. There's not a big area of scar facilitating a reentrant mechanism. And then if you look at the antiarrhythmic drug therapy, we alluded to this, beta blockers, calcium channel blockers, often an initial option. And if you were to use an antiarrhythmic, I think it's reasonable to use class 1C, flecainide and propafenone in conjunction with metoprolol or verapamil. Very rarely will we do amiodarone or sotalol just because there are a bunch of side effects with these medications. And these are otherwise normal, relatively young, healthy people. And it's often better to perform a catheter ablation and just get them rid of or free of the problem and not give them lifelong antiarrhythmics. And if you look at the guidelines for catheter ablation, it's a class 1 indication for anyone with frequent and symptomatic PVCs or ventricular tachycardia originating from the RVOT in an otherwise normal heart. So here that means it's an indication to ablate for symptoms because they don't have a structural abnormality, they're not in congestive heart failure. And particularly if it's originating from the right ventricular outflow tract. And that recommendation is mainly because it's a relatively straightforward procedure. You go in through the venous side, go into the right ventricle, you go into the right ventricular outflow. This image is of the left ventricular outflow, but I think what I'm trying to say is the access to the RVOT is relatively straightforward. The procedure can be done in 2 hours or so, 2-3 hours, depending on the ease. And it's kind of like managing a supraventricular tachycardia. You ablate and they're free of the problem. The same class 1 indication is applicable to non-outflow sites, and that would be the papillary muscle or the fascicular system or the annular system. I think it's important to know that these sites may be slightly harder to get to. You may need more time, you may need more tools to ablate. And this image, this is an NEJM paper written by Dr. Shiv Kumar from UCLA. This is basically showing the left ventricle, the catheter is coming retroaortic, and presumably this is a left anterior fascicular origin because this is where those PVCs would arise, or you may have focal myocardial arrhythmias, and that EKG would look slightly broader. And then the 2A indication is trying to highlight the fact that it is still okay to ablate, but more difficult areas, that is the LV summit, which is an epicardial area, or somewhere in the epicardial system, a parahischion, which means it's right next to the his or one of the conduction fibers. And the class 2A indication is mainly to say that there are increasing side effects, so you've got to really weigh the risks and benefits of ablating those areas. And all of this you can try and figure out just based on the EKG. That should give us, and I have a representative example data here. I just want to highlight a couple of studies, or one study here. This is kind of the basis of our recommendation to say class 1 catheter ablation for RVOT, PVCs of VT, even before metoprolol. So this is a study comparing RF versus antiarrhythmic medications for treatment of PVCs from the RVOT site. And if you look at the endpoint, we don't have time to go through everything, but it was a randomized study, 160 patients in either group. And this included all antiarrhythmics, but the RF group, the radiofrequency group, had much higher recurrence-free survival. And this is just because antiarrhythmic drugs, as we all know, even for atrial fibrillation and such, the efficacy is never upwards of 60 or 70%. And then if you choose a benign antiarrhythmic drug, at least you don't have a poor side effect profile. But if you choose things such as sotalol or defertalide, you have to also deal with the side effect profile, and some of them are proarrhythmic. We talked about patients with structurally normal hearts. What about PVCs in people with cardiomyopathy. And again, this is sort of, you have to figure out, is it PVC occurring in someone with a pre-existing structural heart disease, or do we think this is a primarily PVC-induced cardiomyopathy? Similar, and this is similar to what we talk about AF-mediated cardiomyopathy. And so here, the impetus is greater. If you can get the PVC taken care of either with antiarrhythmic drugs or ablation, the idea is that their cardiomyopathy would recover. So I think the goal of achieving or restoration of normal rhythm and suppression of the arrhythmia is even more important. So this is a class 1 indication. When it's, and the classic thing is if it's PVC-mediated cardiomyopathy, it's often, and the ones that would be more successful with ablation, it would be ones which are frequent and monomorphic, because then it becomes easier to map and ablate. If they're multimorphic, which means multiple sites, the concern would be that they have probably underlying heart disease and you have multiple areas that are firing. You can still do them. It's going to be a tougher ablation, but certainly that should be in the back of your mind. And this is the sort of class 2 indication. Already known structural heart disease, and they have frequent PVCs. They may be monomorphic or multimorphic, as in arising from multiple sites, probably in multiple areas of the same scar. It is still worthwhile considering an ablation if they're not suppressing with antiarrhythmic drugs, mainly because you'll help their cardiomyopathy. So looking at the mechanism of having a normal heart, how do PVCs cause a cardiomyopathy? It comes from LV dyssynchrony, because again, it's if you're having PVCs from the RV side or the LV side, it's like pacing that single chamber. So the interventricular synchrony goes away. You lose your AV dissociation, and you have the irregularity. These are the same 3 mechanisms that are important for AFib-mediated cardiomyopathy as well. And then there's sympathetic dysregulation. There's probably also some role of additional calcium overloading, and all of these then cause myocyte level remodeling. And if fibrosis develops, that becomes a little irreversible. So it's important to try and address these before there's established problem and the cardiomyopathy becomes irreversible. So, and then there are several, obviously, not just anecdotally, there are several studies showing that ablation, and then you can normalize their LV function and dimensions. All right, so how do we ablate PVCs? We'll talk about this for 5 minutes and then go into talking about VTs. So how do we ablate PVCs? It all comes down to understanding the anatomy of the heart. So this is a very classic slide. So we're looking at a gross anatomy picture of the heart, looking from the top, sort of the surgeon's view. So if you're standing right where the atria are, the atria have been separated, and then the right ventricular outflow tract is the anterior-most structure, very close to the chest, where your lead V1 and V2 would be. PVCs originating from this area would direct themselves away from the anterior wall. So V1, V2, V3, a large part of that would be negative. So more left bundle. The more anterior you are, more left bundle the PVC or VT looks in V1. As you go posterior RVOT, that just is sharing a wall with the anterior LV outflow tract and the cusps, aortic cusps. And this is the LV summit area. And as you go more posterior, you have the mitral valve, and we see a lot of ventricular arrhythmias arising from the mitral valve annulus, particularly the lateral mitral valve annulus. And because it's a far more posterior structure, more basal structure, we'll see a different EKG pattern. They'll be right bundle. So the more anterior you are, you have more of a left bundle morphology of the arrhythmia. The more posterior you are, you have more of a right bundle morphology, because as you can imagine, any PVC originating from this area is going to go towards V1, that's going to be positive. It's going to go towards V2, that's going to be positive. And if it's all the way at the back of the heart, even it'll be positive all through V1 through V6. So that's important. And then conceptually, there's more to, it's important to localize it in sort of a 3-dimension. It's important to understand the PVC, kind of get an idea of, you got to geolocalize the PVC origin. So if it's higher up in the heart, which is anything which is outflow tract, you would expect that the activation would be high to low, and that would mean leads 2, 3, and AVF would all have positive, large positive QRS complexes. So that tells us, is it high or low? And I already talked about, is it positive in V1 or negative in V1. That kind of tells us, is it from the left ventricle or the right ventricle? And then concordance, we talk about this in VT. If it's originating from the mitral valve annulus, that's way away from the chest leads. So V1 to V6 would all be positive. So that is the concept of concordance. So we try and localize this based on these set of leads. And then the laterality is 1 in AVL. If it's arising from the left lateral wall of the heart, it would be negative in 1 in AVL. So typical leads to look at are V1 and then the precordial transition. Look at 1 in AVL tells you left versus right. And then look at 2, 3 and AVF tells you high versus low, superior versus inferior. Again, so this is more conceptually, if you look at it, this is a view of the posterior aspect of the heart, sort of tilting down on that histology image that gross anatomy picture that I showed you. A lot of arrhythmias come from this area, from the mitral valve, the summit area. And then let me see if I can localize this for you on this EKG. So this EKG shows PVCs. And if you look in V1, it's positive. Anything that is a right bundle complex in V1 means it's coming from the left ventricle. That's step 1. So if you look at this, we're looking at it from the back of the heart. So that means we have localized it to the left part of the heart. The next thing I would look at the lateral leads, 1 and AVL. It's predominantly negative in those two areas, which would mean, so we already said from the left side, it's even further leftwards because 1 and AVL are leads that would go here. So it's going away. So we've localized this to the lateral aspect of the left ventricle. And then finally, look at 2, 3 and AVF. They're predominantly positive. You could argue that 2 has a positive negative. But if they're predominantly positive, it means it's coming from this higher area. So this would be localized to the mitral valve annulus. And this is what we saw in this patient. And we took him to the lab here a couple of months ago. And this is what we saw. This is a 3D electroanatomical map of the left ventricle. This is the coronary sinus that goes around it. The mitral annulus would be right here. When we map it, we are looking at these PVCs. When we map it, what we're looking with a high density mapping catheter or the ablation catheter is to see where it's originating from. So if you're trying to look at where it's originating from, sorry, let me change this up. So where it's originating from, so you see the earliest electrogram. So that's the local electrogram. This is the holy grail of ablation. You've got to find that needle in the haystacks, as we explain it to patient. But what all it means is that's the site that is this problem for this PVC. The rest of the myocardium is depolarizing normally, but this site is earlier. And you see the signal over here. That electrogram is much earlier than the onset of the QRS. That's how you know that's where it's originating from. In this map, early is white. And you can see that it is kind of a point origin and it's spreading away from that site. We ablated here and terminated this PVC. A second example, another case from about a month ago, contrasting. So look in V1, there's a broad notched negative complex. So when it's a left bundle, it's either coming from the right ventricle or the interventricular septum. Same concept, look at 1 in AVL. It's the exact opposite. It's positive, which means it's further away from the left side and it's coming towards the left side. So it's somewhere from the right ventricle is what we would say. And then 2 is positive, 3 is negative. So it's not high up, but somewhere mid-wall. And this was localized on, so this is a map of the right ventricle, right ventricular outflow tract over there, right ventricular apex over here, atrium over here, we've sort of cut it out. The yellow dots show the His bundle, and this is a classic EKG finding of a parahisian kind of PVC, which is originating right close to the His bundle. So you have to be very careful ablating this. It's nice to identify where it's coming from. So this is that same PVC in the mapping system. And when we look at the signal, it's super early, about minus 30 milliseconds early, which means it's an endocardial site. It's easy to ablate right there. But what you've got to be careful about is the His bundle is very close by. If your catheter moves and you ablate the His, you give that patient a device. And that's a complication you don't want to have, particularly if it's a young and normal healthy person. So this one suppressed over there, and this is the EKG. We got rid of the bigeminy, and I think his cardiomyopathy is on the way to recovery at this point. All right, before we move into the VTs, I think, so I emphasized that understanding the EKG pattern is very important, and now there's tools to sort of simplify it, use AI and it goes into a database and very accurately it can tell us where the PVC comes from. And again, a very experienced electrophysiologist will be able to do this. This is day in and day out. You look at EKGs and you want to challenge yourself to where it's coming from, go to the case, and if it's from exactly the area that you thought it was coming from, you feel good, and then you also, it builds on your practice, and that's what this AI is doing, So I think as we integrate this into clinical practice, it'll make mapping and ablating these easier. These are not immediately available widely commercially, but I think in the near future, these sort of tools will be available. All right, so I'm just going to show you the same concept. Let's say we talked about PVCs. The same concept is applicable to idiopathic VT. So it's one side, structurally normal heart. So this is that right ventricular outflow tract. This is a case from a couple of years ago. Again, this is a map of just the outflow tract. So we have the RV over here. This outflow tract is going to the pulmonary artery. His over here. This is lower down in the RV outflow tract. I'm going to play it. We've mapped it. And as we're ablating, we sort of lose there's excitation of that area. We see VT, and as you're ablating, you see suppression of the arrhythmia. And effectively, these patients do very well if they have a structurally normal heart. All right, we've talked about this. I think the current state of knowledge for antiarrhythmic drug versus PVC, a lot of these are RVOT PVCs, not a lot of randomized studies, a lot of observational studies, kind of leaning towards ablation being more helpful, especially if it's an RVOT sort of origin, but there are several studies coming up. I think the reason I wanted to put this slide up is there are studies coming up comparing this, and then I think we'll have more solid recommendations moving forward with this. So I just highlighted the easy to ablate PVCs, the right ventricular outflow tract, or the right ventricular or left ventricular annulus. So this is a flavor of the really difficult to ablate left ventricular summit. So what is the summit? It's this area where if you look on the outside surface of the heart, you have the left main coronary artery splitting up into the left anterior descending and the left circumflex. So it's right next to that. So obviously very close to the arteries. The distal tributary of the coronary sinus runs here. That's called the anterior interventricular vein. So this summit is this area on the epicardium. And then to make this even more complicated, because you're surrounded by blood vessels you don't want to injure, to make it even more complicated, this area has a lot of epicardial fat. So even if you were to get into the epicardial space and put your catheter there, you're not going to get to the myocardium. So this is difficult to ablate. So how do you ablate? You've got to find out. So these are bipolar ablation. You use ablation, basically techniques to ablate from either side. So this graphic is showing ablating from the right ventricular outflow tract, just below the pulmonic valve. This is from the left ventricular outflow tract, just below the aortic valve, and you're kind of sandwiching it. And this is how it would look on X-ray. This is from the pulmonary artery. You see the catheters being looped down. And then from this side, you're trying to get into this intramyocardial sort of deep in between. And then you can also use this great, if the vein is large enough, you can go through that great cardiac vein and try and ablate on either side. Sometimes this is still not possible. You may get there, you get a great signal, but I'll show you a case. So this is a case, a very similar case that I did earlier this year. This catheter is from the aorta back into the LV, and it's sitting right next to the aortic cusp. And we have a catheter sitting way out there in the coronary sinus, and we know it's coming from here. And we were able to get an ablation catheter out. So the signals tell you we've mapped it, this is the area we need to ablate. But the problem is you do a coronary angiogram and you can't ablate, because if you do, you will cause coronary spasm and probably induce VF on the table for that patient. So what we did here was we took out the ablation catheter, performed a venogram, and looked for all these branches. And we find one of these branches that goes into the myocardium and delivered alcohol there. And that's one of the techniques that is used to manage these LV summit arrhythmias. And we were able to suppress the arrhythmia. So this is contrast and alcohol injection directly into the muscle through that. So this is retrograde venous alcohol ablation. All right, for the remainder of the talk, I think this is important sort of base to understand. And then we'll talk about VTs with structural heart disease and ischemic and non-ischemic. So second question, sort of to think about, a 52-year-old male with ischemic cardiomyopathy, VT, has an ICD placed a couple of years ago, now presents with ICD shocks. Despite the use of amiodarone, what is the next best step? You increase amiodarone, you add a second antiarrhythmic drug such as mexiletine, consider catheter ablation, or, well, I don't think anybody would choose this right away, referring for a heart transplant. Certainly recurrent ventricular arrhythmias, that is a bona fide indication for heart transplant, but that's typically multiple antiarrhythmics, multiple failure.
How's it going?
All right. So when we think about structural heart disease, this is what it looks like, a lot of scar. So this is an LAD scar. You can see RV and LV. So this is probably where the left anterior descending area would go. The anterior wall has scar. The premise of any VT with heart disease is that you have a lot of scar tissue and you have a lot of normal tissue. So the scar tissue serves as one limb of the reentry where the conduction is slow, denoted by these wavy arrows, and then it jumps through the faster conducting normal tissue around it, and it sets up a reentrant loop. And this is a very, very classic figure. Sort of this concept was early 90s by Dr. Bill Stevenson when he was at the Brigham and Women's Hospital and currently at Vanderbilt. This is the classic model of reentry. Is you have in a large area of abnormal tissue, and let's presume that this is a prior MI 10 years ago, large area of scar, you have some surviving channels that are able to conduct slowly. If the whole area was completely dead, you wouldn't have VT. If you have some surviving channels in between, this is where the electrical conduction is slow through them. And then when it comes out, the rest of the myocardium is ready, or it has depolarized and repolarized, and it's ready to get excited again or depolarized again. And that spins around quickly and then comes back. And it's sort of the perfect storm where two pieces of adjacent tissue are ready to be activated and are recovering in a fashion that a reentrant loop sets up. So depending on the scar, the rate at which the VT runs depends on the size of the scar. The bigger the reentrant loop is, the slower the VT is. And I think, back in the day, you used to have huge scars. So you used to have a lot of slow ablatable VTs, and that's how all of this work came about. All of these patients were being ablated in ventricular tachycardia, hundreds of patients, and they were being meticulously mapped to identify. The only way you could ablate it is identify that slow conduction zone and burning there, just those areas. But nowadays, the scar sizes are smaller because people are getting, TPA, they're getting PCI. But when you get VT, you see faster VT cycle lengths. And that's why, we don't see a lot of these hemodynamically stable, large ischemic cardiomyopathy VTs that we can map in VT and do all the classic maneuvers. And I'll differentiate that in the next 10 slides or so. Again, if you look at it on histology, you will see some areas of fibrosis, which will give you very abnormal looking electrograms and viable myocardium. That's a prerequisite for reentry, for this to happen. And this is how ischemic scar would look like. It would be transmural. And this is how non-ischemic would look like. And again, this is a bunch of different diseases lumped together. Sarcoid would be scar tissue right in the middle of the muscle, the so-called intramural. This is hard to get. It's hard to get to that area with a catheter. It could be epicardial in conditions like, sarcoid could have it, myocarditis could have it, Chagas disease is the classic thing. So these are all harder to get. In a way, ischemic is easier to get because you can reliably get into the endocardium of either the right or the left ventricular of the left ventricle, and you would ablate it from the inside for the most part. And this is where the importance of cardiac imaging. So differentiating ischemic versus non-ischemic. So the top panel is ischemic. These are late gadolinium enhanced sequences, dense scar in the anterior area. So we're seeing left ventricle in short axis, right ventricle over here. This is anterior, this is inferior, this is septum. So this is a large LAD territory scar going from the anterior anteroseptal to the inferior area. You see the entire thing is transmural. In to out is all scar. So you can go ablate this from the inside and you would affect the whole, for the most part, you would affect the whole of it. Now, it's very easy to imagine if that scar was just in the middle of the wall, such as in sarcoid, as in this patient, you could go from the right ventricle, you could go from the left ventricle, but you'd be in contact with normal tissue. You're not in contact with the abnormal scar tissue where the VT is originating from. So it's harder to reach areas. And it's just a sliver of scar that can produce these arrhythmias, and they're harder to get to. And that's the basic concept. And apart from cardiac MRI, now we have late iodine-enhanced cardiac CT scans, and you can reprocess it. And this concept came out of the Bordeaux group in France, where you're taking extremely thin slices of the CT scan, and you're able to basically look at the channels in the scar tissue. So densely scarred areas in this area, low thickness of 0 would be these red areas. And again, densely scarred areas do not participate in the VT because there's really nothing they can contribute to in terms of the channel. So a certain thickness, you need to have certain surviving myocardium that sort of sets up the channels. And you can see very clearly here, so normal thickness, yellow, this is all normal, dense area of scar. And then you have these certain areas where this can set up for channels. This will increasingly be adjunctive imaging to help us understand where the circuits are when we go oblique. Non-ischemics, in some patients, there's a role for PET scan. If you see a PET scan like this is uptake in the left ventricle, dense uptake, I would say, the entire left ventricle. This is classic. This is from a patient in India with, that we had seen with classic sarcoid. You don't ablate these. You manage these with anti-inflammatory medications, steroids, let them suppress. Because if you go and try to ablate these, you will have an unsuccessful procedure and potentially with a complication. So using all these pre-procedural imaging is very, very important. Biopsy, as I said, rarely we would do it in sarcoid cases, signal averaged EKGs in ARVC cases. So this is a patient with ARVC. You see a fibrofatty infiltration in the right ventricle, but also it can happen in the left ventricle. The term ARVC are right ventricle, but increasingly we've recognized, and a lot of work has come out of Johns Hopkins, we've recognized that the left ventricle could be affected by the same thing. And you see that you have fatty infiltration and replacement, and that produces abnormal areas. So, obviously we're going to talk a little bit about how to ablate these or how the ablation would look like, but antiarrhythmic drug therapy-wise, you would start with class 3 drugs, amiodarone, sotalol, dofetilide. You would not use the class 1C. Propafenone and flecainide are contraindicated in patients with structural heart disease, and we have very classic randomized trials from the 90s that show increased mortality using them. As a second-line agent, you would use lidocaine, mexiletine, and then you would use also procainamide quinidine later on. And then this question is to say, in patients with hemodynamically unstable ventricular tachycardia, can catheter ablation be performed without causing hemodynamic deterioration? True or false? So I talked about, ablating in tachycardia, which means we're letting the tachycardia run, and then you find out where it is, and burn. But the problem is that's a sick heart that you're keeping in VT for a few hours on the table. They may not tolerate it. If they can tolerate it, this is how it would look like. This is VT running. This is, scar tissue in the LV on the septal side. You're able to terminate it. If it's in tachycardia, same concept. You go find where the early side, where it's originating from, and you can burn it. If it's a big area of scar, you would do techniques. You would do some pacing maneuvers to try and find out that critical isthmus, that slow conducting zone in between. And we won't go into all of these, but there's concepts of entrainment. You can pace and understand where it's coming from and burn. So for example, you have this huge area of scar. You're not going to ablate the whole area. If you're in VT, you can identify the critically important areas with these pacing maneuvers, and you can ablate it. And this tachycardia terminated with ablation at one point. I would argue that you would still do some additional ablation to prevent future arrhythmias. So substrate guided is you don't have people in VT, but you just look at it in sinus rhythm. You look at all the abnormal areas in the scar, and you go look at these local areas, and collectively these electrograms, which is the local electrical activity, these abnormalities are called lavas, which is local abnormal ventricular activity. And these are all targets for ablation because they're representative of that circuit where that set up VT. So you're doing this in sinus rhythm. So you would go in, this is how our modern tools look like. We're going into the left ventricle in about 15 minutes or so. We are creating a high density map, which gives us information of what is normal tissue. In this map, the purple is normal tissue, the red is abnormal tissue. We often have an intracardiac echo catheter, which is showing us the areas we are mapping. And then you look at where, I'll go to this next one. So in sinus rhythm, this is a large area of scar. And now what we're looking at is look at how electricity flows through that. And you see how slowly it goes through that. I'll replay that. And now picture the circuits that we saw on the CT scan and the graphics. So you can imagine that these slow conducting zones are your putative target sites. And you can ablate all of this like that. It would look like that at the end. And then you can have no VT at the end of it. So in terms of indications, anyone with recurrent VT, especially if they have an ICD therapy despite antiarrhythmics, it's a class 1 indication. You should ablate them instead of adding more antiarrhythmics because that has been shown to have better survival. So 3 or 4 slides, wait or ablate. This was a very important study, Vanish study published a few years ago. People on amiodarone coming with an ICD shock, you escalate to amiodarone plus mexiletine or refer them to ablation. We don't have time to go into all the details, but the graphic, the endpoint is people with ablation do better. So then the field is moving towards, do we do early ablation? Do we do it at the time of first ICD shock or multiple ICD shocks? So what about first ICD shock? And this is the Partita trial. So if you do it at the first ICD shock, again, VT recurrence is better when you ablate earlier on. What about if you ablate first line? So you have VT, you are implanting an ICD, but you're ablating before the ICD shock. And there's a bunch of trials, SMASH VT, VTAC, SMS, Berlin VT. And the message has been a little more mixed, but the meta-analysis kind of suggests that you could consider this in certain patients where early ablation, and this is the most recent study, it's called the PAUSE STD, and I'll show you the graph from that. Earlier ablation, so ablating even before they have an ICD shock seems to have better outcomes. So if you start applying this to clinical practice, there would be a huge burden of patients who would benefit from ventricular tachycardia ablation. I think overall in the cardiology community, I think the mindset is still to ablate only as a bailout when you're having multiple recurrent ICD shocks, but the data are fairly clear that the initial ICD therapies, even anti-tachycardia pacing therapy, initial VT, we want to prevent those ICD shocks, and they do better with that. And that's what these studies are all highlighting. So this sort of summary slide is ablation versus anti-arrhythmic escalation, and we're now sort of in the era where ablation is better before ICD shocks are present. I mean, you would still try one antiarrhythmic drug, but a lower threshold to ablate them. And it's better because they're not in cardiogenic shock. They're less sick when it's early on and the patients do well. And then, obviously this is a slide highlighting amiodarone toxicities. Amiodarone is a great drug in suppressing arrhythmias, but a really terrible drug in terms of long-term complications. So you may have to offer people ablations to get them off of these kind of drugs as well. Couple of slides on non-ischemic. So these are much harder to ablate, like I said. And the guidelines kind of reflect that in non-ischemics that you may have to consider epicardial ablation, which means you go from the pericardial area to the outside surface of the heart. So this is a patient with recurrent VT. The map, and this purple here is normal voltage. We created a high density map, looks completely normal. So what are you going to ablate here? So either you have this patient in VT, or you have to look for areas where there's abnormalities. And then I'm going to move past this slide. This is just showing how an epicardial VT would look like. The EKG looks very broad and has, again, classic patterns that would highlight that it is epicardial. This is the broad slurred EKG. I won't go into this because this is a talk for electrophysiologists, this part of it. But if you see that, you would go subxiphoid percutaneously into the pericardial area and map on the outside surface of the heart. CT scanning is often helpful. You're going in this space between the xiphoid and the left costal margin, going at this angle, trying to avoid the diaphragm and going into the right ventricle. And then we went and mapped large area of scar on the outside surface of the heart, and these are areas where we found abnormal areas and ablated, and we didn't have any further arrhythmias. This was a case from a prior institution. So all this is fine, but obviously there's a lot we can offer with catheter ablation, but we have to be mindful of the complications. And it depends on how acutely sick the patients are. So anyone you're ablating in VT storm, electrical storm, the risk is higher. I think the mortality rate can be as high as 5%. But outside of that, if you can manage them, suppress, control, and then bring them back in a more stable area, I think the complication rates overall, you could keep it to below about 1% or so. I have some slides just showing additional techniques, and then we will stop. This is, a subset of patients with left ventricular assist devices who develop arrhythmias, and we can ablate them as a stable hemodynamic VT. And this was a case we did last month here. And you're able to map out that circuit. You see that figure of 8 circuit. You know exactly where it's coming from. You see a lot of local abnormal areas. We ablated there, terminated the ventricular arrhythmia, and then additional ablation. Alcohol ablation, I think I already showed you a slide for the PVC. The same concept is for any other areas of scar that are originating from the epicardium, especially in patients where you cannot get into the epicardium. So this was a patient who tried to get into the epicardium, but he had prior pericarditis, so you could not freely move into that space. So we used the veins on the outside surface of the heart to map and ablate. Cardiac radio ablation, you may have heard about this in patients where catheter ablation is very challenging or unsuccessful. Non-invasive radio ablation, so finding the areas where the VT is coming from and then delivering radiation, basically cancer therapy, radiation therapy to cause uniform fibrosis in that area. You would use this. Certain centers in the US and Europe are doing this, and you would do it as a bailout essentially at this time. Autonomic neuromodulation, stellate ganglion blocks, renal denervation. And then the new kid on the block technology-wise is going to be pulse field ablation. This is now commercially approved for AFib. Studies are ongoing for VT, but basically you're not trying to heat the tissue, which is what radiofrequency ablation is. Here you're delivering a pulse of direct current electricity, and that's causing myocardial death. So mapping is important, but then you're able to effectively ablate a large area much more quickly. So you could convert these 6 to 8 hour procedures to hopefully 2 or 3 hour procedures. So we'll see how this pans out. And then ultra low temperature cryoablation is, so freezing the tissue is another technology that's being evaluated. I think we can stop here. I have a couple of slides on VT storm and management, but I think we'll stop for questions. Dr. Williams.
Thank you very much. Try to get the lights.
Oh, no lights. Okay.
I have a question.
Yes.
Okay, I have 2 questions. I'll start with questions. Number 1, very good slides, very good presentation. I like the colors and very professional way of doing it. So thank you for that. So if you need to do MRI for your patient, but your patient has pacemaker, defibrillator, can you still do MRI? If not, what's your alternative? That's
perfect. That's a very timely question. So we just put in place a protocol with Dr. Downs, the radiation safety officer, to do MRIs in non-conditional. So the newer pacemakers, defibrillators are all MRI compatible. So if they're MRI compatible, you can do them, and that is routine. We just do them. Usually there's some programming changes we make during the study, and then we reset it after the study, and that's approved by the FDA, and we have the manufacturers helping. The issue is, what do we do with all these older devices? Obviously, even with the newer devices, you have MRI compatibility, but you have some artifact. And there's the radiologist and the cardiac radiologist or MRI imaging cardiologist will try and mitigate that. But what do we do with patients with non-conditional, old devices that are so-called not MRI conditional? You can still do them. We just have a certain protocol that we have in place, certain criteria that we look at to adjudicate the risk. But so we have a protocol now here. We will start doing them on a case-by-case basis.
Okay. And my second question, if the ablation fails to correct the problem, either like right away or later on, what's your options?
So typically you would consider more than one ablation if it's failing. And again, the idea is, why are they failing? Is it just a very large area of ischemic that you just need to ablate more? The first ablation, you may have done a limited ablation just to tackle the clinical tachycardia, but if you have more of the same from ischemic, I would take them back to the lab and do that more extensive ablation. But if you're failing because you cannot get to that area, it's deep inside the interventricular muscle, say a sarcoid, that you've tried, alcohol ablation, bipolar ablation, all these techniques, and it's failing. Options would be radio ablation. You could consider that. And then ultimately, someone with unablatable recurrent ventricular arrhythmias, those are the people you would consider for either LVADs or some sort of advanced heart replacement therapy, transplantation. That is still an option. Before we do that, we will also do stellate ganglion blocks, cardiac sympathetic denervation. We could have the surgeons, take down the adrenergic inputs. So you would do all of these things before we move on to, or you do this in parallel as you're working them up for a transplant. These are palliative measures. If it's not an easy ablation and you have multiple recurrences, there are several measures to palliate, and then give the patient a few years at a time, hopefully.
A couple questions.
Dr. Atreya, it's really nice to have the wonderful presentation. A lot of information to digest. The question is about, we have the latest tools, and I'm glad you mentioned machine learning kind of making into the area. So the question is about preventive measures. Before the patient is on the table for ablation, could we really, either by, say, imaging or artificial intelligence, machine learning, we could catch up those patients early on and start putting them on non-toxic interventions and try to prolong the real, complications of ablation or something like that?
Yeah, I think obviously we all know who are the patients who are at risk for ventricular arrhythmias, and it's all these people with prior MIs, and if we have seen them and they're at risk, they would often have a defibrillator, and you're monitoring them routinely. Every 3 months or so, the defibrillator sends in information if there's arrhythmias that are occurring, in a shorter basis. The issue is the non-toxic drugs you would do are things like beta blockers, and amiodarone, again, very long term is an issue. So I think I would do amiodarone initially, but at some point, if they're having a lot of arrhythmias and getting therapies, then it's better to ablate and then use all the tools, use your advanced imaging, know the area. So you can then ablate them when they're not coming in the throes of an electrical storm. They're acutely very sick, and the mortality rate of that procedure is going to be 20%. If you do this ablation more electively, focused, you have an area that you want to target with the imaging, you can do a 2-3 hour procedure in a more controlled fashion and prevent them from getting into that situation where they're present to the hospital with storm and you have to do all these other things. I wish there were better antiarrhythmics that we could put people on. We use a few classes of antiarrhythmics. They have their own set of issues. So, thank you.
A couple real quick questions, because I know we're out short of time. One is that PVC cardiomyopathy issue. It's really tough to try to pick out what level, and it's probably because a continuous variable.
Yes.
But the literature would tell us that 10,000 is dangerous. If heart rate is 70 average throughout the day, they have about 100,000 beats. So 10,000 would be about 10% or so.
Right.
But others say no. If it's not above 20%, it's probably reverse. That is, the cardiomyopathy is causing the PVCs, not in the reverse. So, is there a level that you feel comfortable with?
I think somewhere exactly where you said, in between 10 to 20%, any of that can cause it. I think the classic thought was 20%, but we also have recognized that not all PVCs are the same. So the concept of interpolated PVCs, the timing of the PVCs, interpolated is right in the middle of the other native beats. So you could have a lower percentage, but if it's one of these sort of PVCs that are more prone to causing cardiomyopathies.
Mhm.
You know, we've ablated patients with 10% PVC burden and had improvement in ejection fraction. It's hard because it's heterogeneous and it's hard for the data to, for the data to sort of show that. And like you said, PVC variability is a very big thing. PVCs are notorious for having a diurnal variation. They may have a high burden in the morning, high burden in the evening. You may see them in the clinic with 20% burden. Next week, you bring them to the lab and it's 5% burden. So that adds to the complexity of mapping and ablation. But in general, I think something about 10% is probably PVC-mediated cardiomyopathy. 20% and above, almost more. I think eventually the data hopefully will show that. I think there's a case to start ablating before the myopathy develops, because 20% and above is more than likely to cause issues. And if it's not causing cardiomyopathy, it's causing symptoms. So one of these two indications.
So last but not least, to have an expert like yourself up there, what the whole world wants to know, now that LeBron and Bronny are playing together,
right?
And then you had Damar Hamlin coming back, are people with commotio cordis at future risk? Should they not be playing, or should they obviously can't do contact sports with a defibrillator? Is there a role for ablation, or at least looking for something structural and then doing something to prevent these high-priced athletes from having another event?
Yeah, I think I'm sure they've all been imaged extensively with all modalities available to us. But I think imaging is very, very important, and all of them have complementary roles. So if they have a large area of scar, yeah, I mean, that's sort of, we're pushing the envelope. But if they already have defibrillators and you want to prevent a future event, I think the data is already clear. We know we can target. There are centers in Europe that are not. They have imaging data, and there's tools that you can integrate that with your mapping data.
Yeah.
So you know exactly on the map where it is. You go map 15 minutes, you know the areas that are abnormal on the cardiac MRI. You go to that area, ablate, your procedure is done in 2 hours. And I think you tack down the risk of a future arrhythmia more than 80% or so. So I think there's certainly a role for that. But again, those kind of cases is a lot of shared decision making. It's an elective procedure. The patient and you have to discuss that and move forward. You know, the indication is not as clear as someone who's admitted in the hospital with an ICD shock.
Right.
That is absolutely very, very clear. So, I mean, I have ablated patients with their first episode of VT after discussing with them, ablated first, and then the next day defibrillated, and then they've gone home. So, yeah, to prevent the future events. So, yeah, it depends very much on, that becomes a shared, classic cardiology shared decision-making sort of situation.
Well, thank you. It's amazingly informative and just highly instructive. We're glad that you're here, and we're really thrilled that we have a good place to centralize these patients and get them treated. Thanks so much. Okay. All right. Oh, and before you go, how about that?
Thank you.
You get a Louisville Slugger bat.